My name is Dr. Joe Goldberg. I'm a clinical professor of psychiatry at the Icahn School of Medicine in Mount Sinai in New York, and we're here today talking about PTSD, or post-traumatic stress disorder, and in particular, we'll be talking about current and future treatments for PTSD. So I want to begin with a reminder that we understand PTSD as an abnormal response in the brain to some fundamentally threatening experience that occurs. It may or may not be outside the realm of normal, but it involves threat to one's safety, well-being, possibility of being injured, threatened, killed. It could be an assault. It could be a verbal or physical or sexual assault. It could be a natural disaster. It's some event that evokes, well, in our brains, the fight or flight center. So think back in your memories to the part of our brains that you've learned about in school that's responsible for judging safety in the environment. And if we perceive something as unsafe, we either fight, flee, or freeze. Neurotransmitters are chemicals in the brain that set up a cascade of signals will lead to the body and the brain both responding in ways that may either be maladaptive or adaptive to perceived threats and enormous kinds of stresses. When those responses are abnormal, we start to think about the body's ability to handle chemicals like cortisol, hormones that tell the brain, run away from this threat or stay and fight and not freeze. And when the brain gets caught up in those problems in ways that it can't fully process, we see symptoms such as rumination, nightmares, flashbacks, re-experiencing, reliving, irritability, a whole host of problems that could just make it very difficult to respond effectively. So we think about treatment when someone's improperly diagnosed really from two standpoints. One is pharmacological, the other is more psychotherapeutic or behavior. Let's talk a bit about both of those things. So I said a moment ago, if the fight or flight or freeze center in the brain is kind of in an overdrive state, there are medicines that can help re-regulate that physiology. There are two medicines currently that the FDA has approved to treat the symptoms of post-traumatic stress disorder. They're called SSRIs, or selective serotonin reuptake inhibitors. Two in particular, Paxil and Zoloft, a bit older medicines from the 1990s, are commonly used FDA-approved first-line treatments. There's another class of medicines that affect serotonin as well as the chemical norepinephrine called SNRIs. An example would be the drug Effexor. And then there's a host of other kinds of medicines that have been looked at. So this is an area where there's a great deal of research that's ongoing to expand our pharmacopoeia to develop new technologies and new physical strategies for modulating this fight, flight, or freeze response in the brain. Again, it's sort of bring down the bandwidth. It's normal to have an emotional response, but not this kind of response. So the goal is to really try to regulate the physiological response. One of the emerging areas of interest is psychedelic medicine. You may have heard of a compound called MDMA. That's currently a substance that's not FDA approved for any particular use, but in the year 2024, some research was put together looking at the use of MDMA to assist the psychotherapeutic goals in PTSD recovery. And the FDA decided when it reviewed that application that there wasn't enough information available yet to make this ready for prime time. The FDA didn't say this is not a useful treatment. The FDA asked for more studies around both safety as well as efficacy. So that's another area of emerging therapeutics. Neurostimulation, brain stimulation with something called transcranial magnetic stimulation is another technology that's thought to help modulate the fight or flight response in PTSD. It involves a magnetic coil that sets up an imperceptible electrical field to stimulate brain areas that we think might not be properly responsive to the threats that come to the brain in people that have survived PTSD. So that's another emerging and exciting area of research. Now, in the world of psychopharmacology, we're interested in modulating particular kinds of neurotransmitters, receptors, and circuits. So it turns out there's another class of medicines that goes by the name of atypical antipsychotics. They were first studied in schizophrenia, or ailments where people can't tell what's real from what's not real. Their level of apprehension and hyperarousal begins to make it hard to know what's objective reality and what's not. Turns out some of the medicines in that family are being looked at in a kind of repurposing way, not in psychosis, but as augmentations of SSRIs, such as Zoloft, to try to augment the effects to treat PTSD. So there is a medicine, for example, called Rexulti, for which there's some recent data showing its augmentation to the SSRI Zoloft can have a very significant impact on PTSD symptoms. There's also an older atypical antipsychotic called Seroquel. It's often used for just anxiety symptoms. There's some recent data looking at its value all by itself for combat-related PTSD. So a lot of ongoing investigational work in this area of atypical antipsychotics is yet another area of potential breakthrough pharmacology developments. Now, psychotherapy, behavioral approaches are really meant to help someone unlearned and overlearned response. Imagine if you touched a hot stove and now your brain is pre-programmed to flinch every time you see a hot stove or anything that looks remotely like a hot stove. So exposure-based therapies are really the gold standard in trying to modulate the brain's response to things that can evoke this hyperarousal reaction. Exposure therapy is one approach. Something called eye movement desensitization reprogramming is another approach that essentially involves tamping down the over-response in the brain that occurs when exposed to a stimulus that evokes this dramatic response. It's almost trying to extinguish behaviorally the over-response. Sometimes behavioral approaches are usefully paired with medicines. Sometimes one or the other is an approach. It's a very independent, individualized, personalized medicine approach to the patient, depending on the nature of the trauma, the persistence of the trauma, and the target goals of treatment. And our takeaway from today is that treatments exist for PTSD. There's a great deal of research that's ongoing, and there's a great deal of optimism about the prognosis and outcome for people with PTSD.